Welcome everybody. We are going to start our series of webinar. This is our second series in clinical toxinology related. I'm your chairperson for this afternoon. My name is Ahmad Khaldun. I'm attached with the emergency department of our National University Hospital in Kuala Lumpur. So we have a very interesting topic to discuss today. It's about snake-related injuries in Southeast Asian countries during this COVID-19 pandemic. We have a very nice lineup of speakers this afternoon, and we'll be representing some countries in ASEAN which face quite a lot of high burden, I would say, with regards to snake bite and envenoming. So let me first introduce you to our program. The first session will be a short presentation by each representatives, and this is followed by the forum, which will open a Q&A, a question and answer session towards the end, and all participants who are in this Zoom meeting will be encouraged to ask questions or type your questions in the Q&A button below, directed to the respective speakers or in general. Please do not type or key in your questions in the chat box because that will not be recorded as a question for the participants or for the presenters. Okay, so let me first introduce to you our two moderators. The first one is Dr. Sabrina Safari. She's an emergency and trauma department consultant in Raja Permaisuri Bainun Hospital in Ipoh, Perak, Malaysia. She is currently the Vice President of the Malaysian Society on Toxinology and consultant for the Remote Envenomation Consultancy Services, or REX. Her clinical special interest is in clinical toxicology and toxinology and CBRNE training. Our second moderator is Dr. Zainal Abidin Muhammad Ismail. He's an emergency and trauma department consultant from Hospital Tengku Ampuan Afzan in Kuantan, Pahang, Malaysia. His special interest is in emergency medicine, clinical toxinology, pre-hospital care, and disaster medicine. So both moderators will be moderating the question and answer during the forum session, and I will be chairing the session for the presentations. So let us begin with our first speaker and second speaker, as both are from Malaysia. So we will allow our Malaysian consultants to begin the session. The first speaker will be Dr. Reza Murad Kamarudin. He's an emergency and trauma department consultant from Hospital Melaka, Malaysia. His special interest is in clinical toxicology and emergency medicine. The second speaker from Malaysia, following Dr. Murad, will be Assistant Professor Dr. Aida Sharini Muhammad Shah, and she is actually director of the Poison Center in IIUM, or International University, International Islamic International University in Kuantan, Pahang, and she's also the emergency physician in the hospital. Her special interest is in toxinology and toxicology, and she's also a pioneering emergency physician for IIUM. So without further delay, I would like to invite our first speaker, Dr. Reza, to begin his presentation. Thank you.
Thank you very much, Prof. Khaldun. So I'll be presenting on certain topics, while actually Dr. Aida will take over the few other topics that we want to cover. So disclaimer, this data that I'll be sharing with you is obtained from Malaysia Biodiversity System and REX consultant data that we gathered throughout the years. So objective, I be browsing through snake of medical significance in Malaysia, and as well as a little bit covering on AV, antivenom that we have. So a little bit introduction of Malaysia, as we have participation from other Southeast Asian countries. So we have west and east part of Malaysia, where in the northern states of Peninsula, we are bordering out with Thailand. So this is actually to highlight to our participants that some of the species that it is actually not indigenous to us might be reported here at the states that border up with other countries. So there are total 13 states and 3 federal territories, with total population of roughly 33 million, with majority of the population is actually in Selangor, in Sabah, Sarawak, as well as Johor, the southern part, southern state in Malaysia. So I would like to highlight few misleading or inaccurate information that we might come across. So for example, this is actually the Boya Rusli that is actually being shared in the one of the web page in our Ministry of Health. So clearly this is actually not indigenous and can confuse our readers. So I recommend to be very cautious in seeking information and get through to the correct to the appropriate web page or source of information. Just to highlight, as we want to talk about the effect of COVID-19 restriction of movement with our cases. So in Malaysia, we rather want to focus from March up to right before 10th of June. This is period where majority or very strict restriction in movement actually are applied. So therefore, we want to look whether or not this actually has any effect in the snake-related injury that we have gathered. So there are at least 26 species that can cause life-threatening bites to human in Malaysia, and majority are actually from 2 families, the Elapidae and the Vipividae. Specifically for us, is actually Crotodile subfamily. So we only have pit vipers in Malaysia, yeah. And reported injury is about roughly 650 per 100,000 population per year, with mortality rate is 0.2 per 100,000 population per year. So I would like to draw your attention to this pie chart. As we can see here, majority of the injury is actually caused by our Naja species, followed by our pit viper, that is the Trimecerus purpuremaculatus, our Malayan pit viper, as well as I include as well our python, the Malayo python, as it actually contribute to significant percentage in our snake-related injury reports. So roughly, if we were to total up and to calculate the percentage, it actually contribute to about 21%. So meaning venomous snake bite compared to total snake-related injury, it is actually contributing to about 21%, which is actually similar to previous report that we being actually seeing by Ismail et al. So they reported about 25%. And if you were to look through from the year 2018, 19 and 2020, the pattern actually remains of the same, meaning it is more or less a similar pattern, whereby majority of the injury is caused by the Naja species, followed by our pit vipers, and as well as our python. So specifically in interest of COVID-19, so I would like to highlight here. So during the month of March to June in 2020, when we compare to the previous 2 years, the number actually more or less remain of the same. Even though if you see maybe some increment here, so if I were to calculate the statistical significance, actually it becomes of no significance, meaning the number, if we will compare in the previous 4 months, is actually of the same, whether due to COVID comparing to the non-COVID era. And if we were to look in the breakdown according to the states, I would like to highlight few states that actually reported quite a huge number of snake-related injury. So that be the centrally, it is Pahang, up north, Perak, and then in Borneo, we have Sabah and Sarawak, and Selangor. Selangor, probably because of the highly populated, as we have discussed earlier, one-fifth of the population is actually located in Selangor. So if we were to compare from the year 2018 up to the 2020, the same states actually reported a majority of the cases. Whereby if we were to look here, according to the breakdown in as per the species, as we have seen through the pie chart, majority are contributed by the Naja species, followed by our pit vipers. And probably the number here, I would like to draw your attention here, like our Malayan pit viper. All the cases that we see or reported were from the northern states of Peninsular Malaysia. So meaning, if we were to look, there are no reported cases from the central, southern part, as well as the Borneo. So this I would like to highlight because later on when we are looking at the antivenom of choice, probably that we have to pay special attention to the choice of antivenom that you would like to stock up. And the numbers, if we were to see comparing to the previous years, also record the similar pattern. And just to put it into sort of like easier graph so that we actually can appreciate. So these are from the March right up to the June as due to the COVID-19 movement restriction. And I selected, I would like to highlight few states that record a huge number, that record high number of snake-related injury. If we were to look at the pattern as we have calculated statistically, actually it is not significant because the pattern here, there is no peculiar pattern to it. It's very sporadic, it's very random. So in conclusion, I would like to say from the Malaysia perspective here, that the COVID-19 doesn't cause a different pattern of snake-related injury in our country. And majority of the injury or the bite actually occurs outside of their home. Now, home I define as the house and the nearby garden. Yeah? I mean the garden to the house. Anything beyond the garden, the house compound, I will put into outside category. So majority actually occurs in the outside of their home environment. And if you were to look at the age distribution, it is very logical. It occurs in the working age group, mostly, with the peak at the age of 22 to 25 years of age. And this pattern remains the same throughout the 3 years data that we have. So moving on to anti-venom in Malaysia, we actually embarked in manufacturing the anti-venom more than 30 years ago, but it didn't take off well. So Malaysia resorted to purchase anti-venom from other countries. Now, when we resort to purchase, I would like to highlight that the anti-venom specificity is, to neutralize the venom actually varies geographically. So before 2011, Malaysia were purchasing Indian polyvalent antivenom, and University Kebangsaan Malaysia, where Prof. Kaldun is practicing, is the first to revise this, because we found that the antivenom that raised were actually not from the species that we have, therefore it rendered actually inefficient. So our procurement of antivenom now mostly is actually, majority is actually from Thailand and Australia, whereby if we were to look, the green pit antivenom, it is raised against Trimesterus alborabris, and this has actually very good efficacy towards neutralizing our Trimesterus complex species. Hematopolyvalent, the antivenom is raised against our Malayan pit, our Trimesterus alborabris, and Russell's viper. But this actually, probably we have to pay attention. So in a state that has no Malayan pit viper related injury, probably actually hematopolyvalent is of no use, as it doesn't cover Calocelasma, and we have no, actually this Daboya is not indigenous to our country. So therefore what we basically covering is actually just Trimesterus complex. So therefore it is actually more efficient and more logical to stock up green pit anti-viper. And our neuropolyvalent antivenom is, the antibody is raised against king cobra, Naja cautia, Bungarus fasciatus, and Bungarus candidus. So therefore the selection of the antivenom, we should actually be focused on the indigenous species in relation to the medical significance in Malaysia, and as per the local snake-related injury or reports that we have. And therefore the hospital should stock up appropriate antivenom so that actually it be more efficient, more cost-effective. In relation to treatment or access, in Malaysia we have no difficulty, or there's no report or such report. So we have actually excellent network of pre-hospital care and emergency medical care. And antivenom is included in part of the compulsory drug schedule, whereby it is actually widely available in all the district and as well as tertiary public hospital. And if, for example, any particular district or hospital actually they run out of antivenom, it is very easy for us to mobilize the antivenom to that particular center, as our pharmacy network is actually brilliant. Just to share that the antivenom, WHO actually has produced a very nice guidelines for the production. So whereby it actually covers from the methodology right up to the clinical assessment, as well as the regulatory that the countries should do. So in conclusion, the snake-related injury COVID-19 has no specific pattern in Malaysia, and the snake of medical significance to us in Malaysia is Naja species, our pit viper, as well as python. I've included as well, even though it's non-venomous. And the antivenom, it is appropriately stocked up as per needed basis, and we have no difficulty in access the antivenom so far. And for referencing, for the participants, for the audience, we have to be cautious, as there are some misleading information that available, even though in the official Ministry of Health website. And therefore we encourage more REX consultation so that we can obtain more accurate data, as some of the states actually are not reporting or not consulting through REX because they have their experts, local experts. Therefore the data is actually doesn't represent truly what actually total number of snake injury that we have in our country. With that, actually, I would like to thank you so much. That will be the end of my slides.
Thank you so much, Dr. Reza. We'll move on to our second part of the talk from Malaysia. I would like to invite Dr. Aida whenever you're ready.
Assalamualaikum warahmatullahi and a very good afternoon. Thank you so much, Prof. Khaldun, for that very kind introduction. I am Aida. I'll be presenting two parts of in relation to snake-related injuries in Malaysia, and they are the health-seeking behaviors and also what is the healthcare system in Malaysia in place to fight and to help manage snakebite related injuries. Right now, the first part of it is health-seeking behavior. Now, while looking at the literature, there is really not much data in Malaysia looking at the health-seeking behaviors of Malaysians who are being bitten. And actually, there is not much data in the rest of the world either. There is a lot in India, for example, India, Sri Lanka, and also in the African countries, and some of the other Asian countries like Nepal and Myanmar. But truly looking at health-seeking behaviors of victims of snake bites in Malaysia, there is really not much. But so the data that I'm looking at is actually from the REX consultation services. I'm actually one of the new consultants entering the REX consultancy, and my data is very, very, how do you say, it's not very scientific because I have just realized because there is not much data, I needed to, I think I need a full grant to do it because I think it's a very interesting thing to look at. When we were looking through the consultation of REX, there were a few things that we noted. And so we were thinking, right now, what are those things that are affecting victims, whether they will come to seek treatment or not. Okay. So there's knowledge and education. Is that really significant? And then there's traditional beliefs. And then of course there's spiritual and religious. Now, as Reza has already shown a map of Malaysia, we have our peninsula, we have our East Malaysia, and it's actually a multicultural country. So therefore there is multiple beliefs and on various things, including snake bites injuries. Now, sorry. So among the things that we noted during the consultancy of looking at the period during the COVID, what we call the movement control order that Reza has shown initially. So these are some of the things that in the initial treatment that the patient do for themselves, right? Like they put on turmeric powder, they would use gamat. Gamat is actually seal cucumber, and it's a very well-known product which they made into oils, like here. Oops, I can't find my pointer. Like the bottle in the middle that I was showing, it's an ointment or oil that people use for massage. So they like to use that to rub it in the wounds, and then some use salt, some use seawater, and there are some people who believe sucking out the venom would help. And this has led to the production of many first aid kit venom extractors. During our consultations, we don't see this at all. I mean, like the extractors were not used, but these are other things that is very common. And of course, a majority, like I said, I haven't done a statistical analysis of this because that needs time. But on the surface of it, I think about 90% of the victims will tourniquet themselves, or whatever part of the limbs that is affected before they seek medical attention. So are these related to religion, knowledge? Well, yes, it's all mixture. It's an all mixture. When we ask the patient, why did you put salt? And they say, oh, because my father told me to. So there is no evidence, like no known, it's very grandmother hand-me-down knowledge. And the suction is, of course, thinking that, oh, maybe I should just, and I always tell the patients that if you don't have the suction capacity of a vacuum cleaner, you shouldn't do it because you can't get it out. It's not going to come out, right? And tourniquets, of course, everybody knows. The general public thinks that tourniquet will stop the venom from spreading, right? So these are the beliefs so far that we've seen. And I think it would be an interesting subject to look into further because it gives us an idea of what the public thinks. Like, for example, while I was looking through the literature, the Nepalese study looked at a group of people who are living near a reservation, forest reservation, and because in Nepal they really hate snakes, like hates because it's very dangerous to them, and this led them to have a higher risk of trying to kill the snakes. So then that lead to a higher incidence of snake bites. So this fear lead to more injury, but the fear is brought about not by religion or anything. It's just that they see that the snake is very dangerous and scary. So that is something that is not really religious, or more likely because they live very near the forest, and possibly because, so it was very difficult to say why they have a lot more injury. Is it because they are near the forest, or because they look for the snake and kill the snake and then seek medical attention? Right. Now, another issue, another thing that we find during our consultation is that a distance from healthcare facility is a problem, or maybe not a problem, but a factor. Here we're looking at Belawai. Belawai, this is part of Sarawak, which is East Malaysia. Now we had one case of a child who is a fisherman, who was going fishing with his father and was bitten by a sea snake. Now he only reached Sarike. If you could see, I can't use my pointer, but if you could see somewhere down at the bottom there is a hospital in Sarike. And the patient took, from Belawai to Sarike is only about an hour 40 minutes, but the patient took longer because they were out at sea, right? And then, and Sarike is a secondary to tertiary hospital. So in the end, they referred the patient to Cebu, which is another hour away. So the health-seeking behavior, the treatment that they wanted to get is also affected by distance. And Sarawak is actually a huge state. It's filled with jungle and caves. I mean, it has the oldest caves in the world, one of the oldest caves in the world. And the road system is, in some areas, are not very well developed. In some areas, you can only reach tertiary hospitals via the river using a boat ambulance. So these are some of the things that affect when a patient, or how fast a patient would seek treatment. Right now, some delay seeking treatment because when we say delay seeking treatment, because later I will show you about primary healthcare and then secondary, the system in Malaysia is that majority of our patients will seek primary care first. And the delay in definitive management to whether they need antivenom or not is a lot due to primary care having immature management skills on when they want to manage snake bites. We have a lot of patients going to see GPs in primary care and were given painkillers and then sent home, right? It was not referred to secondary or tertiary hospital for further management. Now, we had a patient who had to go 3 times to primary care until was referred because the symptoms were worsening. All right, so now this is also a way of, well, it's not actually the victim's, it's not his part that was lacking in terms of seeking treatment, but it was because of the primary care, or the first person that they saw did not realize that it was an important management. The first aid management of snake bite or unidentified snake bite is that the possibility of observation for at least 24 hours sometimes, unless the identity of the snake is noted and it's not dangerous, is non-venomous, and there is no other symptoms, right? So another issue that we saw is that if you, I don't know whether I have a map. No, I don't have. So again, a lot of these snake bites happen, some by the people who lived, the indigenous group of people who live in the state, but a lot of it happens to people who goes into, like for example, tourists. The area that Reza highlighted, like Pahang, okay, and then Sarawak is a huge area and is covered by jungle. Again, Pahang is also has the oldest rainforest in the world, and thereby has a lot of species of snakes there. And as you can see from the data that he presented, Pahang had one of the highest number of cases. And so a lot of it sometimes is due to tourists entering the area. And So refusal for admission is due to sometimes logistic, like they do not want to be admitted to a hospital that is not home, near their home, and they prefer to be admitted to elsewhere. But again, these numbers are very small. So other than that, we did not really see much religious beliefs input into this. We didn't really see people going to shamans or bomo, what we call in Malaysia, for treatment of the wound first. It was mainly either they treated it or go seek the doctor. Right. Okay. So that's the health seeking that we saw. Right. Okay. Now, when we are talking about the health system in Malaysia, now why is this important? Because it's important in the management phase of the snakebite injury. In brief, okay, we have primary care, secondary care, and tertiary care. I think this is similar to most system around the world. And for each of this primary care, secondary, tertiary, we have the pre-hospital as well for each of it. Now, when there is a snakebite victim, if they are outside and they don't come to the hospital first, we have our pre-hospital first aid. All right, and then now the pre-hospital first aid is either by the healthcare system, like from the hospitals or the clinics, the nearest clinic, or we have our Malaysian Civil Defense or our fire departments. Now, these are the common ones because we go through a single number, 999, or sorry, a single number 999, and this can send out whoever is the nearest. It's either the healthcare ambulance first, or the Malaysian Civil Defense, or the fire department, especially in snake bites. Right now, if they do come, so commonly they will come to primary care first. So we have private GPs and we have also our government health clinics. And these are everywhere. We also have what we call village clinics. They are also available, especially in the remote areas of in the state. And then we also have secondary hospitals. Now, secondary hospitals do not have, not all secondary hospitals have full specialty like surgical, orthopedics, or pediatrics, or medical. So sometimes you need further referral to tertiary for more definitive management. But secondary and tertiary hospitals do keep antivenoms, like what Dr. Reza has mentioned. It's everywhere. Right. So the system of referral then depends on whether you need further secondary referrals. So, for example, for ICU backups, or there is a wound debridement and the secondary hospital do not have orthopedic teams to look into that. So then they are referred to tertiary. So this is a healthcare system when it's surrounding snake bite, right? Okay. So, for example, this is Bertang Valley. This Bertang Valley is in Pahang. If you look at the picture at the back, it's all surrounded by hills. Bertang Valley, we had a case of a patient in Bertang Valley who had a unidentified snake bite but had significant symptoms, right? Okay, so now Bertang Valley is about 24 minutes away from the nearest hospital, Cameron Highlands Hospital, and that is a district hospital. So it's actually a secondary type of hospital, and it does not have full specialty. It has an emergency department, it has an admission, and it has visiting specialists, but they don't have in-house anesthesiologists or orthopedics. Right, so if they need to refer, then okay. So this is the Peninsula Malaysia, and Cameron Highlands is actually in Pahang, the state of Pahang. Right. However, it's actually very near. Hang on, let me just see whether I can have pointer. All right, here we go. I cannot find my pointer. Okay, here we go. So this is where the patient was brought to as a secondary, for secondary treatment, right? But the patient had significant symptoms, and the swelling was worsening, and after secondary infection has taken place, it needed debridement. So it had to be referred to a tertiary hospital. Now, although Cameron Highlands is in Pahang, the state of Pahang, the nearest hospital is actually the state adjacent. So in our healthcare system, the patient is allowed to be transferred interstate. So the I'm losing my pointer again, but the state next to it on your left, if you see Perak there, is Hospital Ipoh, which is the nearest referring hospital for patients who are coming from Cameron Highlands. So that's how it's going. And we have a lot of patients, if you look at to your right, the Taman Negara, Kuala Tahan, we have a lot of patients who are coming up from this area who has to be transported distance, like I mentioned, long distance, in order to get either secondary or tertiary treatment. Right. So that's why the secondary hospitals are also equipped with antivenoms due to this, and especially if these are the areas that has a higher incidence of snake bites. Right. These are the Malaysian Civil Defense that helps us, and the fire department that helps us with snake bite or snake related injuries. And another thing that I want to highlight in the system, in our healthcare system, is that snake bite victims are allowed to ask for compensation. Now, I'm sorry, I don't have a poster that is more international. This is in Malay. Now, this is a way to help victims recover. And the maximum payout is actually ringgit Malaysia 20,000, and it's usually given for death or permanent disabilities. Now, it is related to wild animals. And as you can see at the screen at the bottom, these are the animals that are considered for the compensation. Right now, the latest data that I have was in 2016, whereby there was 257 cases, and 187 were from snake bites. Right, and then there was some from wild pigs, and then crocodiles, monkeys, and elephants, and the others were from the other smaller groups. Now, a total payout during that year was at the RM 35,000 ringgit. Based on the data that Reza has presented, you would assume that there would be more payout. But I think a lot of the public does not know that they can actually get these services, right? But you have to prove that that this animal bite is genuine, because we have a lot of people who are snake handlers, snake wranglers, and they like to do snake shows, and so we do not consider them as legit claims, because they are actually putting themselves in the risk of snake bites, so they do not get to claim. So the claim for this is for those who are accidental bites. Right now, there are 15 animals, wild animals recognized, as you can see there, and like I mentioned, it's for death and permanent disabilities only. I think that's all that I want to highlight during this presentation. That is the last of my slides. Thank you very much. Hope to hear for some questions. Thanks.
Great, thank you so much. Thank you so much, Dr. Aida. That's a very interesting so-called follow-up from Dr. Reza's presentation. So during this COVID-19, I think our health system is still running, and that's why we still get snakebite patients coming into the hospital, even though they are not coming on their own or something like that. But because the health system is in place, we're able to retrieve the patient, and some of them are actually medevac by helicopter in the from the remote areas. Just one thing that in terms of the tourists getting bitten, I think that's so far, even though Cameron Highlands is a tourist area, most of the cases are actually because of human activities. Cameron Highlands was very highly developed for plantation and also vegetable growing. So a lot of cases in Cameron Highlands are actually from the workers in the farm, so rather than actually in the wild. So as you can see from Dr. Reza's presentation also, that's very interesting. Most of the cases actually in the urbanized area, populated areas, rather than actual in the forest, jungle, remote areas. Even though there are cases mainly from the local, orang asli, but they also come to the hospital. That is very, very encouraging. It shows that our health system has penetrated quite deep into quite remote areas, and it is accessible for all. So that is very interesting, I think. So in terms of management, snakebite in Malaysia, I think it's we are okay because I think the system is actually is in place. And antivenom is also easily available and penetrated into the secondary hospital as well. So that helps. And of course, training has to be continued, both for public and also for healthcare providers. So thank you so much for your input. I would like now to introduce you to our third speaker, which is Dr. Vanessa or Dr. V from Vietnam. So Dr. Vanessa is actually the consultant emergency, let me see here, attending physician in Cho Ray Hospital department, and also a guest clinical lecturer in the Department of Resuscitation, Emergency and Medical Toxicology, and University of Pharmacy and Medicine, Ho Chi Minh City in Vietnam. So Dr. Vanessa is a clinical lecturer in medical toxicology, and also she's in the emergency department as well. So without further delay, I would like to invite Dr. Vanessa to present. Yes, Dr. Vanessa, whenever you're ready. You can switch on your mic.
Hello everyone. So I'm from Vietnam. So here you see is the map of Vietnam, right? So I'm from Ho Chi Minh City. It's from the south of Vietnam. So actually in southeast. So you see on the map, you see so in Ho Chi Minh City is in southeast. Today I would like to talk about in general information about snakes bite in Vietnam. So as you know, in Vietnam, so we have a 37 venomous snake, and also it's there dangerous is found in Vietnam. But in clinical, so we only saw some of them, not all of the 37 snake. The venomous snake. So on the slide, so you can see, so we had Ungarus, so NASA, and also Ophiophagus, so and as you know, it's a king cobra, and also the Pradophis, miniatus, and also Malayan pit viper, and also Tremorosaurus ambularis. So this is the main, the snakes. So we can see every day in my hospital when the patient come to my hospital. In average in my hospital, so this is the number, the total number in my hospital for every year, the patient with a snake bite they admit to my hospital. So you can see the average case about every year. So we can receive 1,000 cases per year. And I just tell you more about information in other hospital. For example, but my hospital, they are from the north of Vietnam. This is Hanoi City. This is the capital of Vietnam. So, for example, in my hospital, every year they have about 500 cases per year. And in Hue is a central of Vietnam. So they have also about 300 cases per year. And Bumeto or Pleiku is a mountain area. So they have about 200 and 230 or something like that. So you can see that about, and also in the South Vietnam, they also have a service house like Dong Tang. We have a Dong Tang snake farm, but they are also the health service there. So they also the patient, because that's in the south. So there are many provinces there. So it's very near them. So they can go to the health service of Dong Tang next farm. for to treat for treatment about snake bite. So in that place, so they told me that every year they have about like 2,000 cases per year. Yeah. So if they have a more severe case, so maybe the patient were severe, more severe, they can transfer to my hospital. So you can see the total case every year in Vietnam. Maybe we can have about 4,000, right? Or 4,000 K per year. I mean, so I just tell you the number here. So that's in the famous hospital, in the big hospital in my country. I cannot count this. Maybe they have a smaller number in provincial hospital, but because we don't have any information from them, so I cannot say anything. But in general, every year, so in Vietnam, we can have about 4,000 cases per year of snake bite. But when the patient has snake bite, so what they will do for the first step? So most of them, when the patient come to hospital, so they will see, they can tell you about that. So they can go to see the herbal practitioner to do something, because they say a snake bite here, so they can use the herb for snake bite. Maybe they can apply on the bite mark here, or they can drink it with the powder or something like that. Yeah. And so I can show you on the screen, so you can see that some kind of herb, and they think that they can give a benefit to the patient with snake bite. Yeah, or they can, for example, for the green leaf on the right side, so they can, how to say, they can chew the leaf first, and then they apply on the mark bite. Yeah, so they think that it will be help for the snake bite. For the habit of the patient, if they think that maybe they cut the bite mark, so I think I mean, from my experience, when the patient come to my hospital, I think it's really easy. They have something happen. Sometimes it happen, but I think it's rarely. Not many cut the bite mark, so to take the venom out. Yeah. But most of them, they know how the garrote, they will tie upper the mark. For example, the mark here, they will tie here because they think that they can prevent the venom can run up. So most of them, they know, and they will tie it here. So they tie with the rubber ties. On the way, they go to the hospital. And if they can catch the next, so they can bring us, they can brought the snake to the hospital, so we can see, okay, what kind of snake, so to confirm what kind of, so we can easy to decide to use the anti-venom. But sometimes they didn't bring the snake to the hospital, so but they describe, so we can show them the picture of the snake, so because they don't sometimes, because they are from the province, so maybe they some of them they don't know how to use the smartphone or to show, or on the internet to show you the picture of what kind of snake. So we can look at the bite mark or in the clinical, so we can guess what kind of snake, and then we can ask them to describe how the snake look like, what the color, what they do, or something like that. So we can even show them, and so we can yes, or we can know what kind of snake. And for the education, I think that if we search on Google, so on a website from many hospitals in Vietnam, so they can they also have the guideline. This for people, I mean, for in general education about snake bite for people, how to do if they have a snake bite, what to do, or something like that. So if the citizen or the people in the province, if they can read it, if they have mentioned, so I think it's help to people. But I think in reality, I'm not sure all of them will read that. But if we say that we should have do something on the internet, so we look like we can spread out the education. But I think so we did. But how to make the people pay attention to reading this is still is the problem now. And from the pandemic, so I can say that because from pandemic, so that's it, limit in the hospital we also have a limit patient. So we also have less cases of snake bite from the March, right? I think from the February, until I think April, yeah, April, and then and now we have the second how to say the second part. So we have look like the pandemics like image again. So in Vietnam, so we also have a time for limit the patient. So on this last time, we receive less case of snake bite. But recently, I think the case I show you on the screen. So I think maybe most of you know it because it's very famous. Because I know that in social media, they spread out very fast in this case in Vietnam because the patient have a king cobra by him and he brought the snake to the hospital and the snake at that time still alive. Yeah. But when the patient was transferred to my hospital, the snake would die already. Yeah. And luckily, this patient, we have enough neuro antivenom for him. Neuropolyvalent antivenom for him, enough for him. So so today he's okay. So you can see after by about, I think I remember this is after 48 hours. Yeah, so yeah, he has a necrosis there on the abdomen, and then after that the patient has an amputation. So and now he's discharged, and I think the wound is good. So I hope he can be better in future. And about the healthcare system in Vietnam, I think so I focus on the snake bite. So as you see in the north, so we have a Bach Mai Hospital. You see the center, the big center in the capital city. So most of cases of snake bite, they will go there to Bach Mai Hospital in the north. Yeah. For in the central of Vietnam, I think they will go to the Huế Central Hospital. And in the south, so two places is Dong Tam Snacks Farm is a healthcare service, but it's a small place, but they also have antivenom there, so they can treat the patient. So and then my hospital, Chai Hospital. So most of the case will be severe. Yeah, if from the local hospital or provincial hospital, if they receive the patient, so and then they can transfer to my hospital because some of them they don't have antivenom there. But some provincial hospital they have antivenom, but maybe I think they don't have much experience to use the antivenom for the patient for just a severe case, or maybe they feel that they don't feel safe to the patient, so they will transfer to my hospital. For the quality of care for about the snake bite, in my opinion, I said that rather good because most of case of snake bite, so they will go to the big hospital. So we have experience for the treatment. So and also in the hospital, in the big hospital in the city, and we have an antivenom for them. So I think so it's rather good. For the financial support for the treatment of snake bite, so most of them they have a health insurance. So the health insurance will pay 80% for the treatment. So they will pay 20%. So this is the anti-venom made in Vietnam. So we have two kind of anti-venoms. It's a Nazacatia and also the Temesurus abularis. So you can see the price about $18.5 US per vial. It's made in Vietnam. So for Nazacatia, so I think so we can use about 2 to 1 or 2 or 3, so in average. So, but for the Temesurus, so for the first dose, we will use 5 vials, and average, I think maybe to 10 to 15 vials for a case. So I think for the prices, the patient, I think it's okay. Not really very expensive to them. Even they don't have the health insurance, I think maybe still okay, except for very poor patient. So it is difficult. But I mean for average, so it's still okay. But for other snack, for example, for Malayan pit viper, so we don't have anti-venom. So, and also for the neurotoxicity, snakes bite, so we also don't have. We only have a Nazacatia, only that one. So for other one, for bungaros or for king cobra, so we don't have. So we import. So only in my hospital, import. So we bought the antivenom from Thailand for 2 types of this. One is for Malayan pit viper because we have many cases of Malayan pit viper, about more than 100 cases per year. Yeah. So, and also, it's really generous because the bleeding, severe bleeding. So this is very important. So we think that we need to use the antivenom from Thailand to help the patient. But in the south, I mean in the view of the south, is different from the north, because from the north, for example, from my hospital, they don't use the antivenom from Thailand. They only use the antivenom from Vietnam only, so made in Vietnam only. So that's it, only two kind of antivenom, Nazacatia and Temesurus abularis only. But for the case, for example, bungaros, king cobra bite, sometimes they have, so they just have supportive treatment only. Yeah, so they don't buy the antivenom from Thailand. But in my hospital, we're different. We think that, so we should buy it to give for the patient, for our patient. So we do that. For the project in the future, I know that from the Nha Trang, we also say the Buster, the Nha Trang Buster Institute Buster. So they are cooperate together, and also Dr. Tao. Dr. Tao, he is from the Museum of Natural Science. So he has ambitious with the snake. So we did. Dr. Tao, he did many research about snake. So and he submit his project to produce the anti-venom in the Ministry of Health, and also I think so now they start to study how to produce the anti-venom for Malayan pit viper. So I think in the future we can have that anti-venom made in Vietnam. And also I heard that they also will do on bungaros the anti-venom. So I think that they will in the future, but I don't know when. when we will have a new anti-venom. But I think this is the signal, the good signal, right? So because we try to do more for our patient. And because in Vietnam, so we know that, and also many professor ask you. So when we discuss together, and also with a very special snack in Vietnam, for example, Pradofish, subniatus, and also king cobra. So I think not many publication, but now we have the patient. So I think so. I hope so. I think I will save the time to write the manuscript and to share our case to everyone in the world, so we can know more, and so we can learn more about from all of you. So okay, thank you for listening. Sorry, I can hear you.
Sorry, thank you so much for your presentation. I just saying that it is very interesting that we still have a lot of areas to improve on, particularly on the areas of availability of antivenom, how the health system works, and I think the more important also on the prevention area, preventive method in the community, because I probably Vietnam has a bit more close relationship with nature, how people work. Maybe that also may increase the risk. It's interesting also to note that you said the commonest method of first aid is tying the tourniquet. So we find it the same also, I think, in Malaysia. Tourniquet is the commonest first aid the public will resort to. So, okay, that's it. Thank you so much. I will now introduce our next speaker. This is Dr. Jörg Blessman, representing two countries, one Laos and the other is Germany, but he's in Hamburg now. So Dr. Jörg Blessman is from Bernhard Noch Institute for Tropical Medicine in Hamburg, and he is also doing some clinical work in Vientiane. So his special interest is actually in epidemiology of snake bite envenoming and the respective snakes, and also clinical toxinology. So without further delay, I would like to invite my good friend Dr. Jörg Blessman to present. Thank you.
Okay, thank you very much, Dr. Kaldum, for introduction. I will talk about snake-related injuries during the COVID-19 pandemic in Laos, PDR. I'm working there since 15 years, so I got some experience and also experience about the development of treatment of snake bites in Laos. First of all, I want to introduce you the venomous snakes of medical importance in Laos PDR. I refer to the categorization of WHO. So we have category 1 and category 2 snakes according to WHO. And category 1 snakes are the snakes of, they are highly venomous snakes with causing a high burden of disease and also mortality. And in Laos, these snakes, the #1 snakes is actually the Malayan pit viper, especially in southern Laos and in central Laos. In the northern Laos, we don't have the Malayan pit viper, obviously. The green pit viper is the second category 1 snake in Laos, and the cobras, the Naja species, are the third. In the southern part of Laos, we mainly have the Indo-Chinese cobra. In the central part of Laos, we have the Indo-Chinese and monocled cobra. And the northern part of Laos, actually, we don't have that much experience in this area, but there we have probably the monocled cobra as a second category 1 snake. For the category 2 snakes, these are also highly venomous snakes, but the burden is much lower. And in the southern part of Laos, actually the Malayan krait does a lot of bites. I observed this in the southern province of Savanakhet, where 5% of the bites were from Malayan krait. In the other places like central Laos, it seems to be lower, the bites from the kraits. I have actually never saw a bite of a banded krait. They bite obviously rarely. And I never saw a bite of a king cobra, which doesn't mean that it doesn't happen, but they didn't arrive at the hospital. And we saw now in the last year 3 cases of mountain pit viper bites, one in southern Laos and 2 in central Laos. And we saw also 2 cases of red-necked keelback bite, Rhabdophis subminiatus in central Laos. And actually 2 weeks ago, we saw the first case of a small spotted coral snake bite in central Laos. But anyway, these snakes down here, category 2, are less important for burden, for morbidity and mortality. So the category 1 snakes are the snakes which are of most concern. Here are the pictures most of you are familiar with. So we have the family of Viperidae with hematotoxic venom, that is a Malayan pit viper. Actually in Laos we have at least 6 different species of green pit vipers, the Trimeresurus complex, and we have probably 2 species of mountain pit vipers, so I call it the Ovophis complex. The second family is a family of Elapidae. They have neurotoxic venom, and here particularly the monocled cobra, probably mainly in central and northern Laos, the Indo-Chinese cobra found mainly in southern Laos and central Laos, the king cobra probably all over the countries, and then the banded krait, the Malayan krait. These are pictures from southern Laos, and this is a picture of Alexandre Taigny, the French herpetologist. It's a multi-banded krait. The picture is from Luang Prabang in the north of Laos. And also we have the family of Colubridae, and this snake is a rear fang snake, so it's difficult for these snakes to apply venom. But if they are able to apply venom through a long bite, they are kind of massaging the venom into the wound, and then they can cause severe hematotoxic and also nephrotoxic symptoms. And the red-necked keelback, we saw 2 cases with quite severe hematotoxic envenomment. So here are 2 examples for distribution of venomous snakes in Laos. On the left side is the distribution we found in Savanakhet province in the southern part of Laos. So you can see the Malayan pit viper and the green pit viper. These are the 2 major snakes causing problems in this area. And probably this counts also for the other southern provinces in Laos. And we have 25% of Indo-Chinese cobra bites and 5% of Malayan krait bites. On the right side, we see here the distribution of venomous snakes responsible for bites in Vientiane province and in the municipality of Vientiane, so the capital of Laos. And here you can see a little bit more vipers are responsible for snakes, but also you can really see the Malayan pit viper is a big problem, the green pit viper is a problem, Naja species, 10% maybe, and rather rare we find krait bites in this area. Here I summarize the data we collected about incidence of snake bites. In Laos, actually, on the left side here, we have a high burden from two community-based studies, the data from 2014 and 2013, and they are in Champon district, in one district of Laos, of Savannakhet province. We found an incidence of 350 cases per 100,000. In Pin district, which is a poorer district, we found even more than 1,000 snake bites per 100,000 per year. And so Laos has a high burden of snake bites compared to the surrounding countries. This is a study from Myanmar from 2018. They found 116 snake bites per 100,000 inhabitants in one area in Myanmar. I think it was Mandalay. And in Vietnam, in the central part of Vietnam, Tua Tien Hue province, we did a study in 2017, and we found 58 snake bites per 100,000. In Can Tho in Vietnam in 2018, that is the municipality in the Mekong Delta, we found around 50 per 100,000 snake bites per year. And for Malaysia and Thailand, I actually calculated the incidence from the number of snakes mentioned in the website of the Malaysian Society of Toxinology. 3,000 snake bites in Malaysia per year. When you have 30 million people, you have an incidence of 10 per 100,000 per year. And in Thailand, they have around, from the statistics, hospital statistics actually, 7,000 snake bites, and with approximately 70 million people, it's also 10 per 100,000. So that is an idea about the burden of snake bites in the Asian countries. I think Cambodia, I don't have numbers from Cambodia, I don't have numbers from Indonesia, and I think Cambodia especially will be a high burden of snake bites as well, comparable with Laos. So here you have an idea about health-seeking behavior after snake bites. From our studies in Vietnam, for example, you can see Hue, we found an incidence of 172 snake bites per 100,000 per year in the mountainous district, and in this area, approximately 34 per 100,000 snake bites were calculated from hospital statistics. And when you compare the community survey and hospital statistics, you can estimate the percentage of patients treated in hospitals. That is, in the central province of Hue, approximately 20%. In Can Tho in Vietnam, from our study in 2018, we found an incidence of 48 per 100,000 per year, and 22 per 100,000 per year was the number we calculated from hospital statistics. So you see, it's a quite high percentage of people are treated in hospitals in the Mekong Delta, in Can Tho in Vietnam. And also in Mandalay, Vietnam, from the study in 2018, it was calculated from hospital statistics, 44 bites per 100,000 per year, and incidence from community survey was 116. So also in Myanmar, the number of patients treated in hospitals is 38%, which I found is already quite high when you consider that quite a significant number are bites from non-venomous snakes, and a considerable number are also bites from venomous snakes without envenoming. So when you see the numbers from Laos, you see the incidence from the community survey in Savannakhet, Laos, that is already from 2014, so already 6 years ago. We have approximately 400 per 100,000, and then you have calculated the number from incidents from hospital statistics, you have only 4 per 100,000. So in Laos, the number of patients treated in hospitals is less than 2%. So most of the people in Laos, in most areas, are still treated in their village by traditional medicine or maybe in a small health center. So about anti-venom usage in Laos, actually there is no production of snake anti-venom in Laos. and the Lao people depends on antivenom supply from Thailand. Antivenom from the Thai Red Cross is actually not yet registered in Lao PDR, and the regulations for import of antivenom into Lao PDR are also still missing. And the distribution of antivenom to provincial hospitals is also poorly developed. So that is a lot of work to do to improve the situation and to improve the antivenom which is available in the future for the people in each province. For the COVID-19 epidemic or pandemic in Lao PDR and snakebite envenoming, we observed changes in hospital admissions of patients with snakebite envenoming in 2 provincial hospitals during the first 6 months into 2020. But there were only 2 provincial hospitals we got data from, and still it remains unclear to what extent this was caused by COVID-19 or measures to contain the pandemic. Here I show you some data about hospital admissions for snakebite envenoming at Setat Hospital in the capital city Vientiane, and from Champasak Provincial Hospital from between 2018 and 2020. In Setat Hospital, you can see when you compare the number of cases admitted to the hospital between January and June, you see in 2018 there were 103, 125 in 2019, and in 2020 during the pandemic it was 122. So the same number. There was no change in number of admissions for snakebite envenoming. In Vientiane Provincial Hospital, you see here, in 2019 there were 114, in the whole year 212. And actually in first half of 2020, there were only 37. So there was a significant drop of hospital admissions. But I think Vientiane Provincial Hospital ran out of antivenom beginning of 2020, and that is the main reason for the drop of the number of hospital admissions for snakebite envenoming. In Champasak Hospital, you see here 2018 they had 10 in the first half, in 2019 9, and in 2020 even more. But still, you can see here the number of snakebite hospitals and admissions for snakebite envenoming is very low. And Champasak province is a province with 700,000 people. When you calculate, let's say 200 snake bites per 100,000 per year, there should be 1,400 snake bites per year in this province, and only 19 arrive at the hospital, 17 arrive in the hospital. So that is quite a low number. That means the health-seeking behavior is still staying in the village, going for traditional medicine, because antivenom is not yet always available. The knowledge of medical doctors is still not sufficient in some areas, and also financial constraints are there, because most of the hospital care has to be paid by the patients. So if you work on it, you will have more patients in the hospital, and that you can see in Vientiane Provincial Hospital, where we worked for a long time, and usually the antivenom supply is there. You have 212. This is a province with 400,000 people, and you will expect around 800, maybe 1,000, maybe a little bit more snake bites per year, and already 200, that means 20% go to the hospital. That is already a success. And also you see in Setat Hospital as well, antivenom is available in this hospital. The doctors are trained to use antivenom, and then the patients are coming. So now I think antivenom shortage in Lao PDR is the reason that we have a drop of hospital admissions in this certain province in Vientiane. And there is a critical shortage of antivenom, particularly antivenom for Malayan pit viper, which is the most important snake causing envenoming in Lao PDR. And actually Laos received 16 vials of expired antivenom from Dr. Khaldun from Malaysia in August 2020, and more is on the way, luckily for the patient there. And so far, we actually treated 4 patients with these expired antivenoms, monovalent Malayan pit viper antivenom and polyvalent hematotoxic antivenom from the Red Cross. And the treatment was effective in all 4 cases without unexpected side effects. So in conclusion, most likely COVID-19 had no influence on hospital admissions of patients with snakebite envenoming in Lao PDR, but critical shortage of antivenom influenced the number of patients coming to the hospitals. And expired antivenom from the Thai Red Cross provided by Dr. Khaldun from Malaysia was effective in 4 patients. And I think we will use more expired antivenom in the next 2 or 3 months until the Thai Red Cross can deliver again a new batch against Malayan pit viper venom. And finally, Malayan pit viper and green pit viper are causing the majority of approximately 75% of venomous snake bites in Lao PDR. So particularly against these 2 snakes, we need antivenom. Thank you very much for your attention.
Thank you, Jörg. That's a very interesting talk. It's also very important to note that how health system in different ways can actually affect the patients that we see in the hospital, and it may not reflect the actual burden in the community or even in the country, and therefore sometimes comparing different countries with local data that we have may not be appropriate, because there's so many factors that is affecting how the numbers are being obtained or the data are being collected. But I'm also interesting to know that patients know how if the hospital has antivenom or not. Therefore, they will not come to the hospital. It's just very interesting so-called association there. How the patient know that this hospital doesn't have antivenom, maybe from word of mouth or something like that. That the community think that there's no point going to the hospital because the hospital doesn't have antivenom. So this is something that we can discuss in the forum later. So, okay, so thank you so much. We'll proceed with the next speaker. I would like to introduce to you our colleagues from the Philippines. First speaker there'll be 2 speakers from the Philippines. The first one is Dr. John David Comandante. He's from the Department of Emergency Pre-Hospital and Disaster Ambulatory Care Medicine from Hospital Makati, from Makati, and his area of interest is in toxicology, and probably hopefully toxinology as well, and emergency care. So the second speaker from Philippines will be Dr. Francis Bon Blanco. He's from Hospital Ang Muntinlupa in Muntinlupa City, and he's also affiliated with the Eastern Visayas Regional Medical Center in Tacloban. So his clinical interest is in intensive and critical care medicine, clinical toxinology, emergency area intervention, and emergency medicine and ultrasound. So without further delay, I would like to invite the first speaker from Philippines, Dr. David Comandante, for his presentation, and followed by Dr. Francis.
Okay, good afternoon, everyone. So I'll be sharing my experiences when I was still training as a fellow in the National Poison Management and Control Center. The data I'll be showing are the actual cases we received from that poison center. So the National Poison Management and Control Center is situated in Philippine General Hospital, the University Hospital, one of the largest university hospitals in the Philippines. And NPMCC is the first poison center that was established here in the Philippines. So this will be the outline of my presentation. So I'll be first introducing you to our Philippine snakes. The picture I've shown you is actually one of our endemic snakes, endemic cobra, the Naha philippinensis. We have actually 160 species of snakes, 70% which are endemic. Actually, recently one of our herpetologists has recently discovered probably three new species of snake. So this could be updating. No? We're still at infancy in terms of herpetology and toxinology here in the Philippines. But to date, this is actually one of the families of medically important snakes. So as shared in some Southeast Asian countries, mostly are from the Elapidae and the Viperidae. We have actually 4 medically important cobras: the Naha philippinensis, the Naha samarensis, the Naha sumatrana, which is actually shared also with some Southeast Asian countries, and Eopiopogosana. We have so many species of sea snakes, coral snakes, and 2 genus of pit vipers, or Trimeresurus and Providolenus. Our antivenom actually is locally produced, so that's actually one of our advantages here in the Philippines, and it is actually produced in the mandated center for neglected tropical diseases such as snake bites in the Research Institute of Tropical Medicine under the Biologicals Manufacturing Division. Yearly, they produce about 4,000 to 6,000 cobra antivenom, but this is only specific for Naha philippinensis. And actually, their production cost would comprise 2% of the total budget of our ATM. So you can just imagine how the production could be not so focused, no? And hence, actually, recently in the COVID, I'll be discussing later that recently the production has been decreased to 4,000 to focus their efforts on COVID-19, since RITM also is the focal institution for COVID research and development. And perhaps our antivenom is actually the cheapest in Southeast Asia. It costs around $30 per vial, or 1,600 pesos for private institution. But it's cheaper if you procure it if you're in a government institution. Recently, actually, we were fortunate enough that the group from Rex ASEAN, so I'm one of the newest consultants for the representative from the Philippines for the Rex ASEAN. We are actually recently invited to be part of the technical working group for the Philippine Snake Bite Initiative. And one of the goals actually of this group is to do research and development and to gather data, especially for epidemiology and clinical management and training for snake bites. And one of the goals is to produce polyvalent antivenom, first for Philippine cobras, hopefully for more than 3 species, but we have 4 of Philippine cobras by 2025. So I'll be first discussing a short case presentation that I've seen during my stay at the National Poison Management and Control Center. This is actually an 11-year-old male from La Union, the island group of Luzon in the Philippines. So we are divided into 3 island groups: Luzon, Visayas, and Mindanao. And this is actually a poison center consultation for loss of consciousness. This patient was laying in his button at his right ankle. After 5 minutes, which he experienced dizziness, and there was actually alleged decrease in sensorium. Good thing he was immediately brought to a nearby district hospital, which would show you in the map approximately like 20 minutes away. Unfortunately, the snake was unidentified, but given with his symptom toxidrome, we might be suspecting a neurotoxic cobra. When the patient was received from the district hospital, actually the patient had was in coma with fixed dilated pupils. The patient was intubated, stabilized, and pressure immobilization was done. And he was immediately referred to a bigger tertiary hospital in a regional center where the antivenom actually was available. These were actually the physical examination findings by the attending physician at the tertiary hospital. The patient was unconscious in coma, intubated. The pupils were dilated at 8 millimeters, non-reactive to light. His blood pressure was stable. He was on assisted ventilation. You can see the note. I'm sorry, I have the physician was not able to put a scale, but you can see here the punctured wounds was noted at the right ankle with minimal swelling compared to the other. There was no bleeding or necrosis. The assessment then was acute respiratory failure type 2 from the toxic effects of cobra venom, accidental initial counter, and it's a super probable cobra bite. So this was just the summary of what happened during the admission. Upon transfer, the patient was decked for pediatric intensive care admission. The hospital actually was informed us that there were only 5 vials of antivenom left in their hospital. Ideally, it should be more. I'll be showing you our treatment guidelines for the management of your cobra, specifically for Naha philippinensis. But we just resorted to the administration of our available 5 antivenoms concurrent with neostigmine and atropine. Tetanus prophylaxis was also given to this patient. After 4 hours post-infusion, the patient had regained consciousness and was now irritable with no note of ptosis and good strength of 5/5 on all extremities. The pressure bandage was slowly released. However, this patient self-extubated after 1 hour and tolerated room air without saturation. We have noted that also there's actually increased swelling in the foot, but still without necrosis. The attending physician decided to start on antibiotics. On day 2, there was no recurrence of difficulty of breathing nor changes in sensorium, but the patient had fever. On day 4, there was actually significant decrease in swelling, and the patient was discharged without complication on day 6. So what have we learned from this case? Actually, again, so this is just to show you that the patient, under our local guidelines, should have received at least 10 to 20 vials of antivenom as per our local guidelines. So what have we learned from this case? So at least we have seen that the patient had good health-seeking behavior. So the patient was initially brought to a district hospital where early stabilization and intubation was done, which should have helped in the prognosis of the patient. And we actually also learned that there was a good referral and transfer for definitive care. Physicians and despite the lack of antivenom, we have complemented it with some adjunct therapies. So this is just one of the observations we found at the Poison Center here at National Poison Management Control Center. But as you can see here, actually, we had increasing cases from 2017 from 2018 to 2019. But at the start of the COVID season, we see a dramatic drop in the telephone consultations at Philippine General Hospital. As you can see in the 2020 here, this actually were admissions and telephone consults. And at the start of the COVID where we declared enhanced community quarantine at March 15, there was actually the dramatic decrease on telephone consultations, which will actually translate to decreased hospital admissions at other institutions, where the patients would be referring to us for toxicology consultations. So we could see only like 2 or 3 cases per month. So what were our observations? Most of the telephone consultations had prior traditional medicine consults. There was also a report from 2 regional centers where we usually stock our antivenom, but there were actually a shortage of antivenoms. So what would be the observations and what we are actually perceiving? Actually, in the Philippines, we are one of the highest active cases here in Southeast Asia. And you have seen actually there were shifts of priority in terms of treatment. No? That includes also snake bites. Later in the discussion by Dr. Blanco, he'll be sharing some of his experiences in Hospital ng Muntinlupa because it has actually a close proximity with RITM. And now, the Research Institute for Tropical Medicine is actually one of the lead agencies for COVID-19 response. And we also noted that they had actually shifted their budget and decreased the production to 4,000 in vials per year. Concurrent with some reports from other regional poison centers, there's actually a limited production to begin with, and now there's actually more limited. No? So in terms also of procuring this anti-venom, there could be actually logistical difficulties as well because as you also know, we are actually the country with the longest lockdown with community quarantine restrictions. No? Started early in the early phases of the COVID, no? Like March, April. And then there's actually an decrease in hospital consult, even in our hospital, in my local hospital in Makati City. There's actually decreased consultation, probably because the people actually are afraid of my contracting COVID when they visit the hospital. So perhaps there's an anecdotal increase also in tradition. So before they go to a hospital, they try to look for alternative treatments for COVID, for snake-related injury. Lastly, here in the Poison Center, we also actually had experiences of increased utilization of telemedicine consultations. Just this weekend, actually, I had a personal consultation on a snake bite. So how could we be responding to this kind? No? Mostly, the doctors are actually consulting with the poison centers. But right now, there's actually a 60% increase of teleconsultations and try to do correct management for these types of snake-related injuries. Of course, in our end, in Rex Philippines, we're actually continuously giving information and dissemination for appropriate safety-seeking behavior and health-seeking behavior in some of our social media platforms. And one of the challenges actually for our group is also the return to normal activities. Actually, for this year, we already had lineup of trainings for FACS and SEM for other regions to increase just to inform you that actually the Philippine Snakebite Initiative was actually just recently convened in January 2020. However, some of our activities actually were halted when the community quarantine was imposed. But good thing, at least we're trying to go back to our normal activities, and we actually reconvened last September 16, 2022. And with this, actually, thank you for listening for my report.
Thank you, JD. I think that's very, very interesting to note that the activities in the community could actually prevent or reduce the snakebite incident during the MCO or restricted or during the what do you call stay-home order. Maybe because maybe slightly different to Malaysia because people are staying home during the MCO, but they are actually increasing their activity in the house and around the house. And that's where they're cleaning the house and storage room. So that's how the number of bites actually remain almost the same. So that's very interesting, I think. Okay, so to our second speaker from Philippines, my good friend, Dr. Francis Blanco, whenever you're ready.
Hello. Good day. Good day, everyone. During COVID pandemic and the implementation of community quarantine, we experienced nearly zero trauma cases, and alcohol-related injuries. However, I will present to you the effect on the other side of the spectrum, the snake-related injuries in our locality. So the area of scope of our practice became bigger because of the COVID, and our ATM was also focused on COVID frontlining activity. So I'm going to share to you what happened. So by sharing to you our actual cases and management and practices on snake-related injuries while we were in community lockdown due to COVID-19. Second, how does the most common problem of inadequate antivenin affected our clinical outcome? Also, we established an interim multidisciplinary team approach management wherein I foresee the intensive care management of those critically ill patients, actually all of them. So snake bite, severe envenomation included. And then I can call infectious disease for help, general surgery for debridement, and even the orthopedic surgery. Nurses are also even very adept at bedside, mechanical ventilation management, monitoring of the clinical symptoms of the patient. So I made this quotation, saving lives with one purified Cobra antivenin at a time. So here it goes. We have a total of 74 cases just for 6 months. On top of that, not included those who were refused because of lack of space in the hospital. So from March to August 31, 64% of those were discharged alive. 31% of those patients went into home against medical advice, and we had unfortunately 5% mortality rate. So to make a summary, as you can see here, after plotting the numbers of the previous slide, I note of an incidental finding that all the curves are similar. Monthly cases, number of discharge, and those of home against advice, the trend was similar to all of them. In fact, our HAMA case rate was very high during the pandemic at 31%. Patients were afraid to stay longer in the hospital, or they refused to be admitted because of the fear acquiring the virus. At the left upper corner, I'm showing you the COVID-19 nationwide cases data. And it's very interesting to see that when the COVID-19 nationwide cases were lowest, we had the highest number of snakebite cases. So this is true to Dr. Carl's previous statement that because of the lockdown, they are at home disturbing the whatever habitat of the snakes. So during this time, May to June, community quarantine was at its peak, wherein people were really enforced to stay at home. So this is a very good data from the intuition of Dr. Carl that it's actually very interesting. So examining the data further, according to the age highest group was 15 to 24 years old with a mean of 32 years. The youngest we had was 6-year-old boy. The oldest was 79-year-old man. So the most common affected part was the left lower extremity. For the left, males are 3 times more likely to acquire the bite compared to the female counterpart. I would like to present shortly our sad case. This is a 12-year-old male beaten by a snake in their own home while he was going to the bathroom. So he was bitten in the left foot. The snake was seen by the father, but it was very fast, exiting the house. He was brought to the hospital a few minutes, and then the doctor who referred to me said that he arrested upon arrival. So they put resuscitation in one epinephrine, who was revived, subsequently referred to me like 4 to 5 hours later. However, when I received the patient with the doctor for transferring the patient to me, the ET tube was out. So I was afraid of really the patient suffered hypoxic encephalopathy on top of the severe envenomation. So anyway, I tried to do everything to rescue reintubation, give rescue, PCAV, 12 ampules. By that time, we utilize everything that we have and wait for the next stop. However, 7 days later, the patient died. So I'm almost certain that the hypoxemic encephalopathy has greater impact than the severe envenomation. So my conclusion here is that most of our snake bite cases range from dry bite to localized soft tissue. And in fact, some of the comments that clinical observation, Dr. Aida, I think, mentioned about it, clinical observation of up to 24 hours, which we also practice here, was also adequate to monitor and rule out envenomation and to safely discharge patients. We have no documented bounce back to ED with worse outcome. Unfortunately, only 2 of the 74 cases were identified snake species. However, the snake was already dead or through the cell phone picture. Admission rate, that was Cobra actually, Cobra. So admission rate was 18%, only 14 out of 74. So in summary, you can take a picture of this one, that out of 100, less than 20% will be admitted. The rest can be safely discharged with, maybe this is a good thing for them because we only have 1 antivenin. So our mortality so far from March to August 31, we have 4. In summary, 1 dead on arrival because far-flung area, the patient was on prolonged downtime and was shopping to other hospitals and was refused because they were all COVID focused. No bed availability. So when it arrived to me, the patient was already rigor. Second is the pediatric patient I had, with the hypoxic encephalopathy, ET out. We have 2 cases of severe pneumonia, septic shock, but there was actually a precedent snake bite. So we're not sure whether snake bite occurred simultaneously concomitantly with the COVID, but then the chest x-rays, the CT scan proved that they have COVID. These 2 patients actually died less than 48 hours. And so here's our assessment so far. There was a surge of snake bite cases in Osman, which was highest during the time of the countrywide community quarantine. And up to more than 30% of cases opted for home against advice, which fortunately, we don't have any reported adverse comeback. So dead on arrival, this is very common. No nearest hospital able to manage or optimize snake bites or even confident to accommodate patients with those injury. Second, well, I have shown to you 2 patients with severe envenomation with no area management. So this is very good because we can approach this type of direction rather than focusing on, for example, focusing on producing more antivenin. This is how we approach, because I think this is feasible to us, empowering doctors to do area management first, because the patient died with the doctor, with the pediatrician on him through the ambulance, who never really anticipated or evaluated the airway of the patient during the trip. That's really so sad. So because of that, as the head of my department, actually, I made a decision that I will open now a section of clinical toxinology and medical toxicology. So this will be with the blend of the medical director. Picture there, I had my first meeting with the supervisors and how happy they are to focus all the efforts. In fact, we have been receiving many toxicologic patients and we've been managing them. So why not make it a section so that this will become the call center for the far south. In fact, during quarantine, the transportation was very bad. So in fact, there was no transportation. So I think that's really the thought here, that the move. So I think this is a very good effect to the department and to our institution. And I was able to convince the medical director it's about time. And the orthopedic surgeon and spine surgeon actually volunteered great to help support for the extremity injuries when there is debridement involved. Surgical department was also pledge allegiance to the project so that they can do a holistic approach to all toxinology cases. So thank you very much for listening.
Thank you, Bon, Francis, and also JD. It's very interesting to note how the pandemic itself brings out some issues that maybe you can be used as an inspiration to move forward in handling these snakebite issues. I know it's only limited to one antivenom for the Philippines, but I think with a closer tie-up that we have now with RITM, this can be expanded and look at other options of how we can help improve the situation with antivenom supply to the Philippines. Okay, so thank you so much from Philippines. We will move to our next speaker. Actually, we have another 2 speakers, but we will have another commentators later. But our next speaker is from Myanmar, Dr. Myant. Dr. Yeah, just a minute. Let me see. Yes, Dr. Myant Tet Nui. She's actually working in. Is a medical doctor, and she's working in the. She has a master in public health medicine in Tsinghua University, Beijing, China, and went back to serve Myanmar. She is in the university. She is currently focusing on issues, projects about snake bites in Myanmar. So without further delay, I would like to invite Dr. Myant to present the talk. Thank you.
Thank you, Professor Kao, for your invitation. Can I share my screen? Hello, everyone. Good afternoon. And can you hear me?
Yes.
As introduced me by Professor Ka, I'm the public health professional working in Myanmar and working for the now I'm working as a snakebite researcher in Myanmar. And I will present the countrywide, nationwide data for Myanmar as I'm working as second staff in Ministry of Health and Sports. And these the following data will be the copyright by Ministry of Health and Sport. Is not my own data, and these are unpublished and raw data. That's why you cannot cite in anywhere. And let's start my presentation. Oh my God, something happening. And this is the outline of my presentation, common venomous snakes of Myanmar and access to care for the snakebite patients and availability of ESV in Myanmar and snakebite situation in Myanmar. And these are the common venomous snakes of Myanmar. In our country, there are more than 40 venomous snakes, but these 7 species are common venomous snakes, but among them, and medically important snakes, we have 3 medically important snakes: viper, cobra, and green-bellied viper. In 2018 hospital admission data, according to 2018 data, viper bite, according to nationwide data, is account for the 73%, and cobra bite is account for 12%. And the data will vary with the regional lights in Mandalay, and viper bite will account for 85%. And cobra bite will be less than 3%. It will be vary above the regional distribution, but most of the snakebite patients who was admitted to the hospital were the viper. And access to care in our country, like you see in my slide, PowerPoint slide, the lowest level is a village level, and we start with the rural health center, who was run by the health assistants. They are not doctors. And in the large village, there's a station hospital and run by the doctors, and also above that township hospital, district hospital, who are the secondary secondary hospital, and also regional hospital as a tertiary hospital. And in these primary, secondary, and tertiary level, the ASB is available at mostly available in all the hospital, who was run by mostly medical doctor, started from station hospital, situated in the large villages. But in 2020, we finished the training, giving training mostly in virtual to the all rural health center recently, and we'll distribute ASV to all RAC at the end of this year. That's why COVID-19 is not impact in the management level, like the distribution and the accessibility in the healthcare system. And how about the anti-snake venom? Let's look at this. We have the monovalent species-specific anti-snake venom produced by the government-owned factory, BPI, Burma Pharmaceutical Industry. And we have two types, Viva and Cobra. Viva is for the double siamesis, and Cobra is for the Nyaarkaudia. And also I show in the previous slides, mostly hospitally admitted venomous snakes are Viva and Cobra, and also the presenting symptom they are very different. Hemotoxis and neurotoxis. That's why the production of monospecific anti-snake venom for these two species is covered for the whole country. And also the snake bite anti-snake venom production in barrel. Let's look at this. Production is increasing in trend, and previously the BBI cannot produce enough supply for the country requirement. But after the Australian aid government project, Australian aid project, the snake ASV distribution is enough, and now is more than enough than the government needs. And but I'm collecting data because the Professor Carl asked me to present in this webinar, and I'm interested to present which data and can I present in this webinar, and collecting the data of the national data from the Ministry of Health and Sports, and I can get the 12-month data from the Ministry of Health and Sports. It's very interesting for me. Even though the supply and access to care is not impacted by the COVID-19, but the snakebite admission data and the case fatality rate is really interesting for me. And you can see actually 12 months, and I'm interested in I collect again for the last month. That's why it is really about 13 months data for Myanmar. It is a nationwide data, and you can see there's a significant increase in the case fatality rate started from April 2020. And let's see these data into the graphs and figures, graphs. And this is the snakebite trend. We have two spikes, seasonal trend. And this seasonal trend is happening same as before. We have two spikes, one is in the rainy season and one is in the harvesting season, as our snakebite patient, snakebite disease is like the occupational hazard. It's also happening as previous years. And but case fatality rate is interesting, significantly increased after March. After March, it is before March, it is less than 6%. It's around about 5% in average, and after March, it's increased up to the 8%. And let's look at in the previous year, in 2017 is a case fatality rate in average is about 5.5%, and in 2018 it's about 4.8%, and 2019 is about 5.1%. That means it's nearly about 5% in average in last 3 years. In 2020 data from January to August, it's only 8-month data, and is a case fatality rate in average is about 7%. I'm interested and I'm comparing and splitting the data, this segment data into two parts, from January to March and also from April to August. From January to March is about 5.2% is usual and is the same as before. But after March, case fatality rate increased up to 7.5%. And why it is happening like this? It is very significantly and coincide with the COVID-19 situation in Myanmar. Our first COVID-19 case was confirmed on 23rd March 2020. And we did the suspensions and not the countrywide lockdown. Divisional lockdown is done by the government, and there's restrictions like the travel restriction and public transportation accessibility will be impact on the COVID-19 and will be impact on the snakebite patient outcome. Therefore, you can see in this figure, before March, case fatality rate is as usual, and after March, case fatality rate is higher. And also seeing in this figure, you can see in the blue line, case fatality rate before COVID is as usual like previous years, but case fatality rate after COVID is increased up to 7% for the average for this year. And we don't know the exact cause of the higher case fatality rate. I'm not doing the intense research on this area, just only get the raw data. The possible causes of the high case fatality rate will be the afraid of the healthcare facility. It will tend to the patients of the like the longer duration of the peritoneal time, and they are afraid and delaying of the going to the hospital. It will affect on the longer duration of the peritoneal time, and also impact on the snakebite patients' outcome. And also another reason is a travel restriction. It also will be impact on the peritoneal time, because most of our snakebite patients are viral patients. If the longer duration of peritoneal time will increase, get a higher chance of the AKI, acute kidney injury, and acute kidney injury will increase the impact of the high mortality. And another one possibility is availability, reduce availability of the public transportation during the lockdown period. This is just only my personal opinion, my personal assumption on possible causes of the why this higher case fatality rate in this COVID-19 period. And in my country, second wave is starting at the last week of August, and it's severe in this month. And it is interesting what will happen in the second wave. I just want to share this data because the first data you can see, I will show this data. You can see the all the snakebite cases were admitted to hospital as before, and also that cases is less than 100 cases, and you will not notice if you didn't calculate about the case fatality rate, you will not notice about the, and it will not impact. But if you calculate the case fatality rate, it is significantly increased in this COVID-19 situation, and this is this is the main point I would like to share of the situation of Myanmar. And thank you for your attention.
Thank you so much, Myant. That was very interesting data that you have. The relationship between how COVID-19 and the importance of actually calculating the case fatality rate, because if not, we will think that it is quite the same, but it is not. So that's very important input from Myanmar, and I hope the second wave will stop soon as well, because we are actually facing similar issues now in one of our state in Malaysia, in Sabah, and at the same time today we had election day for Sabah. So we just hope and pray everybody is safe over in Sabah and also the whole ASEAN. Okay, so we move on to our last presentation speaker, which is none other than our Dr. Tri Maharani from Indonesia. She is currently the president of the Indonesia Society on Toxinology, and she's currently attached as the head of the emergency in the Daha Husada Hospital in Kediri, East Java. She's actually a champion for snake bite for Indonesia and has done a lot of community work over the years, and I think we are seeing some results from her work in Indonesia. So without further delay, I would like to invite Dr. Maha to present her talk.
Yeah, thank you, Dr. Khaldun. In this afternoon, I will to share the situation, snakebite and pandemic COVID-19 in Indonesia. I think I hope give the information for all from the participants. Okay, next, Doc. Yeah, next my presentation. Dr. Khaldun, help me to my PowerPoint.
Share screen.
Yeah. Next. Yeah, Doc. Next. Hello.
Hello.
Next, my PowerPoint.
Share screen.
Dr. Sabrina will share screen.
Yeah, Dr. Sabrina. Next, my PowerPoint. Okay, Indonesia, a big country, have 17,000 island, over than 17,000 island, and with the people 270 million people. I think a big problem from the snake bite and the problem from the COVID-19. And you know, the species of the venomous snake in Indonesia, 77. And the all total snake species, 370. I think very big snake species in Asia. Okay, next. Yeah, next. Yeah, next, Doc.
Slightly lagging because of the rain, I think.
Oh, okay, yeah. Okay, next, my slide. Yeah, and my data, yeah, okay, Dr. Sabrina, the next slide. And my data, Indonesia toxinology, incident every year, over than 135,000 cases. And I have data from the mini hospital and the emergency department in hospital to the mortality, I think over than 500 until 1,000 cases. But in my data in Indonesia toxinology, then 5,000 every year to the incident. I think many lost data because the big area and my Ministry of Health don't have program from the collecting this data from the snake bite. Okay, next, my slide. Yeah, next slide.
I think it's a bit lagging.
Yeah, the next slide. And Indonesia have many problems. I think same the other country in Asia, Indonesia have problem about the traditional treatment, first aid in the community, and many traditional treatment don't have the people good treatment, but the many fatality and cases in the community. And Indonesia don't have guideline, Indonesia guideline, and many problem in Indonesia about the guideline, the same in the hospital and the other hospital. I think it's the big problem because many doctor and many nurses don't have the same skill of the reduction cases of the snake bite. And antivenom not available. Indonesia have only one polyvalent, covered 3 species, and 2 not researched. And I think it's the difficult high production. Every year only 40,000 production. Okay, problem is the pandemic. Indonesia have the first case in the March, and the lockdown and no transportation make antivenom not available. I have many cases not available antivenom, and delay have medication in hospital or mini hospital. And the second problem is the people afraid come to the hospital or mini hospital because COVID. Afraid because the many cases COVID in the hospital or mini hospital. And the many people jobless, no money. And this pandemic make many cases about delay have medication because no money to go to the hospital or mini hospital. If they have insurance, the people not problem, but the not money to the go with the transportation. I think it's the difficult problem to during pandemic COVID-19 about the snake bite. And cases snake bite causes many cases in the pandemic causes attraction or show because many people jobless, and the many people jobless, we thinking they have the innovation with the attraction of show, but it's very dangerous because many cases fatality. The prevention of COVID-19 stay at home and closed school and all school until now in Indonesia, and many cases snake bite in the children because they are boring and look the television or YouTube and many program about handle snake and the other. I think give the cases of the many children have the snake bite. And the focus government now is the pandemic COVID-19 and the little focus of the snake bite. I think it's the big problem about reduction cases snake bite in Indonesia. Yeah, next. It's antivenom from Indonesia. Covered Caloslasma rhodostoma, Bungarus fasciatus, and Najas petatic. And no have research to Bungarus candidus and Naja sumatrana also. And the doctor Indonesia give the patient biosafe or antivenom to the Bungarus candidus also, Naja sumatrana also. And 5 species include 1 antivenom import from the BioGSL or Securius Australia to the East Indonesia, Papua, and Maluku. but it's very expensive. And now I'm successful to the imported from the KSMI, green pit viper, imported from the holding company Biopharma. Now Biopharma is the holding company. Kimia Pharma import green pit viper to the little hospital to buy from the Kimia Pharma. Okay, next. Yeah, next, yeah. This data, snakebite January until September, and my data in Indonesia toxinology, 256 cases and mortality 31. 19% snakebite show and hobbies, and 10% farmer and children and women. And I have 5 cases in pregnancy, but all cases live, and 60% Trimerosaurus species. Trimerosaurus albolabris, Trimerosaurus insularis, Trimerosaurus phoenicius, Trimerosaurus purpureum, and the other. And 20% Najas futatic. And 10% king cobra, 5% bunga rose, and I have death in the child, 1 cases, and 2% Calloselasma in pregnancy, all life, and 1% rhabdopiece, 1% Calliopiece, and 1% non-venomous. Okay, next. It's pitch from the death case in Indonesia, 31 cases. You look, all cases is show hobbies, and only 1 cases in the child, Bungarus candidus. And I know it's a big problem because the stay at home and the closed school make many people don't have activity outside from the home. And this case fatality, all case fatality is attraction and show. Okay, next. I have the live king cobra bite, the attraction also, and this patient live, but I don't send this antivenom, but the doctor called me, and I help the doctor to give the anticholine esterase to this patient, and the good result, this patient life. And I have many cases, Phoenicius, Trimerosaurus phoenicius bite, Rhabdopsis bite, Trimerosaurus albolabris, insularis, and also. Okay, next. Back doc. Yeah, I have non-venomous cases, but the bad condition, bites, reticularis bite, but the traditional treatment gave the wound very bad, and the fullness apertum very bad. I'm looked to in the hospital and need the heading and the other, and one toilet from the doctor. And I have the special case, Daboya simanensis bite, and the remote island is Nusa Tenggara, and the island named Lembata, very remote island, is the March, and the January cases. And I think it's the first cases in Thailand, but this cases COVID-19 in Thailand. I must fly to Thailand, buy to the antivenom, and go to the Lebata and save this patient life also. Okay, next. Many cases Calloselasma bite, and the special cases because many military must go to the many area in the pandemic COVID-19. Many military have this Calloselasma bite. I have 5 cases military in the area from Calloaslasma bite and cobra bite, Najas putatic and Najas matrana bite. Okay, next. And woman and child have many cases also to the snake bite. I have many child snake bite and woman snake bite also. But all the cases live, especially one cases Bungarus candidus and child in Cirebon is the death because delay from go to the hospital and have medication. Okay, next. Yeah. This pig look many show and attraction in Indonesia. I think one problem because many activity not out from the host and many people jobless, and these people have innovation attraction on show, but it's very dangerous activity. I have 15 cases about show and attraction. Okay, next. And pandemic COVID-19, the innovation from Indonesia, because no training with the many people, the training health worker online, and every weeks I have training for health worker, collaboration with the Indonesia Associate of the Doctor and the Indonesia Associate the Nurses to training health worker about the snake bite management and first aid. And all consultation online, and the WhatsApp and the application of public safety center. I have the application same day speak 119 in Indonesia. And I have the good meeting with the new director of the Bio Farma. She is a sister of the Minister of Finance Indonesia, and I discussion with her about the many cases snake bite and needed from antivenom, and she has agreed to help me to the antivenom, and this collaboration with the holding company, because now Indonesia company of the antivenom is holding company Bio Farma, Kimia Farma, and Indo Farma, and successful to import it green pit viper from the KSMI, from the Kimia Farma. And now hospital needed the Bethesda Hospital in the Yogyakarta. And meet also with the Commission 9, Legislative Indonesia, DPR RI Indonesia, and Minister of Health to the build of the program to reduction snake bite in Indonesia. I hope finish from the pandemic COVID-19, all this program to start. Okay, next. Reduction COVID-19 and snake bite together is the problem in Indonesia. And I am give many strategic from the reduction COVID-19 and snake bite with the many people, community of reptile, and the many people from the mini hospital, from the hospital. I am collaboration with the military also, with the many community reptile to give hand wash and soap wash, and many innovation. You look the stethoscope lung and aerosol bag from the many health worker in Indonesia. I think to get the reduction COVID-19 and snake bite is good result until now, because many cases in COVID, over than in Indonesia, I think over than 200,000 cases of COVID, and mortality from COVID-19 over than 10,000 people. I think must have had homework to all medicine, to all doctor and the nurse in Indonesia. Okay, next. And I am survivor COVID-19. In June, I am in COVID disease, and I am recovery in the July, and now I am start to working also, and give to a group of the survivor COVID-19 in Indonesia. I am foundation from this group, and ask many people to support it, to many cases COVID-19 and the patient COVID-19, also patient snake bite. I think it's the second life to me. And I think it's the second time to I am working, helping many people in the Indonesia. Okay, thank you, Dr. Sabrina. I am finished to my presentation.
Thank you so much, Dr. Mahat. I'm glad that you can be with us today, and I hope you continue to stay safe and be healthy. I don't think Indonesia can afford to lose you from this COVID-19. So yes, it's true. There are so many challenges still in Indonesia. I know this because, as you know, we involved together for snakebite in Indonesia for a long time, and we see that the attraction, the show, actually caused people to hold snake, handle snake, kiss the snake, and the famous, so many people die because of unnecessary handling or bad handling of the snake, and they use big snakes such as king cobra, and there's no antivenom for king cobra in Indonesia. So that was our challenge before. We just hope that with your work in the community will actually increase the awareness and promote the appropriate safety measures, healthcare behavior, and safety seeking behavior as well. Okay, so thank you so much. So now we've completed all our presenters. I would like to invite for the last part, Professor Sataria from Thailand. She's also our advisory member for REX, ASEAN. Maybe she can say a few words regarding the situation of snakebite pandemic during this pandemic in Thailand. Prof. Sataria, can you?
Yes.
Welcome.
Professor Carl. I have a problem
you.
with my camera, so I think
it's okay. You are safe. It's fine.
Yeah,
so,
sorry about that.
Go ahead. Tell us a bit about how it is in Thailand.
Okay. Good afternoon, everyone, and thank you very much for inviting me to be one of the panelists in Thailand, because I work as the consultant in Ramatibiri Poison Center. So from our poison center data, there are about 800 to 1,000 snake bite cases consulted to our poison center each year with very low mortality. The incidence might be higher than this because 800 to 1,000 cases are from only our poison center data each year. And our Thai-Res Cross produce the antivenom both for mono and polyvalent for 7 Cat 1 snakes. And most snake bite cases in Thailand are from like cobra, pin pit viper, Marian pit viper, Marian crate, and Russell snake bite. And the antivenoms are now in we call Thai National Antidote Program, and these programs arrange for the antivenoms stockpile in each hospital. And our poison center help guide the management of snake bite patients by these antivenoms. And I think that during COVID-19 pandemics, the incident of snake bite, the data from our poison center was not increasing obviously, or decreasing, obviously. I think it was quite similar to other periods each year, in each year. So I don't think that COVID-19 pandemic affects the snake bite incidence quite much for our country. Yeah. And also our poison center collected data of anaphylactic reactions from antivenoms, and we found that about 20% of cases had anaphylactic reactions, mostly from Malayan pit antivenom. Yeah, that's all. Maybe I'm sorry that I don't have their slides,
Okay.
but thank you very much for let me talk a little bit about our my country.
So we will now move to the forum Q&A session. I will invite Dr. Sabrina and Dr. Zainal to conduct the question and answer. So we hope all speakers can turn on their cameras, except for Prof. Sataria, of course, and join us. And please ask your questions in the question and answer box at the bottom of your screen. There's a Q&A box. Do not ask your question in the chat box. Okay, and I would like to announce that every participants will be able to download their e-certificate by clicking the Google form that we have included in the chat box. Okay, so before you leave today, please sign in your Google form for your e-certificate. And I would like also to announce that Professor David Worrell has been following us from the beginning, all the way from Oxford, and it is really, really an honor to have him listening to us chatting here. But I will invite him to say a few words before we finish our forum. Okay, all right. So Dr. Zainal, Dr. Sabrina, you can have about 30 minutes for this session.
Hello, thank you, Carl. So we have a few questions in the box, but I think quite a few questions is already answered. So shall we go to the question that not been answered, and if we have time, then we go to the answered question? Yeah, okay. So I think the first question, it is posted by anonymous attendee. Is asking about, is it ethical to treat patient with expired AV, despite I do understand the difficulties in getting AV, and although there is no side effects post-treatment. And the second question is, furthermore, can I know the efficacy and expired AV as well? So just in case if you can't obtain, let's say, sea snake AV, but previously stock was expired, is it advisable to use them? Probably we invite Dr. Jog to answer this question. Then after, probably Dr. Carl can add on.
Okay, I will start. Well, it's true that if we have expired antivenom, you would prefer to have non-expired antivenom. But if you don't have antivenom and you have a patient with a malign pit viper bite with severe coagulation disorder, bleeding from gums, bleeding from the bladder, bleeding everywhere, I think I would personally prefer to have expired antivenom than no antivenom. That is the first thing. Second, I think there are data from Japan also that the lyophilized antivenom against Rhabdophis tigrinus, they produced this antivenom in the year 2000, and they check this antivenom every year for effectivity and safety, and it's still in the year 2020 obviously safety. And we have also 3 vials of this antivenom in our hospital in Vientiane. So that is also argument that these antivenoms are very safe. I would have problems to give liquid antivenom, which is expired, but lyophilized antivenom, the only thing you can expect is that the effectivity is lower than new antivenom. But our experience is that the effectivity is very good, and in all 4 cases, it reversed the thrombocytopenia and the prothrombin time to normal very quickly, and there were no side effects. Yeah, there was one patient with allergic reaction, but that is what we expect also from non-expired antivenom. There were no unexpected side effects from expired antivenom. So I think you are right. Usually you won't give it, but in this special situation, I think it's very reasonable to give it.
I think Prof. Sataria maybe can provide some response to that as well, because QSMI, being the antivenom producer, they probably have a track record of looking and assessing expired antivenom, and I think we have good data from QSMI for that to support as well. Prof. Sataria?
Okay. I have consulted about this expired antivenoms to our director, Professor Vinay, and he said that he will consult to Thai NHSO and GPO about this, because I think that the antivenoms that were expired were destroyed by each hospital now. Yeah. And so I am not sure that how many vial or expired antivenoms were destroyed. So Professor Vinay told me that he will ask up and discuss about this. And I'm not sure that if like in Laos, if you need like the expired antivenoms, is it possible to have like the pathway or documents to ask about this? I'm not sure. Yeah.
Thank you. So actually, there are many other studies also shows that there is actually effectiveness of the antivenom is not really significantly reduced after the expiry date. So it's what you put there is on the shelf date. So some of these are actually well kept. So for example, you are actually continuing keeping the antivenom as it was supposed to be kept, and this will actually maintain the efficacy, not so much, and also reduction in terms of the efficacy. And also the side effects is not really that much different compared to the non-expired antivenom. So obviously, the longer the antivenom there could be, and as Dr. Yok mentioned, the antivenom for the Rhabdophis tigrinus in Japan is still being used and being available to be used, even though they are way expired more than 10, 15 years already now. So it shows there is some potential to use in emergency situation. So if you have the non-expired antivenom, please use that first. But if you can't get, and there is no way that you can get the proper, the non-expired antivenom, and what you only have is the expired one, in terms of emergency care, that is, I think, is allowable within the limitations and also the cautionary measures that we should take for each case. And of course, documentation is very, very important. Yeah, so yeah, that's it. Any question? And next question.
The next question is from Thomas Lam. Fascinating talk from Dr. Tri Maharani. Due to the variety of envenoming species and similar clinical syndromes, do you have challenges with species identification? Is it customary for patient to bring the snake with them to hospital? Dr. Tri? Dr. Maha, can you answer? Can you on your mic?
Sorry.
Yeah, okay, thank
I
you.
have many cases, the patient give the snake, go to the hospital. Live snake also. I think it's very important because all doctors have a little knowledge about the identification. But now I give the education, many people know give this live snake because the photo from snake. I think it's the very safety from the doctor and the nurses in the emergency department. And I think the identification is important from the doctor, especially in the emergency department.
Okay, okay, thank you. I think there's another question to Dr. Tri Maharani from Nosham Yaakob. He asking about what was the bite from Rhabdophis fatal in Indonesia? And good to know yours. Yeah, okay. Was the bite from Rhabdophis fatal in Indonesia?
Rhabdophis, yes, I have, but the Rhabdophis in Indonesia also hematotoxin. This sign and symptom or hematotoxin. I don't have the other sign and symptom, only hematotoxin also.
Okay.
So the next question is to Dr. York. Dr. York, did you seek Ministry of Health approval for the use of imported expired ASV? And we have occasionally used expired lyophilized antivenom in the UK for exotic envenoming. The question is from Thomas Lam.
Actually, we didn't ask for approval from Ministry of Health. So I offered the director of the State-Hatterat Hospital to receive this antivenom and leave them to decide to use it or not to use it. And the patients who will receive this expired antivenom will be informed about the expire date and will have to sign a consent form that they agree to take the antivenom, and that is how we proceed.
Actually, the first patient did not agree, isn't it?
Exactly. The first patient didn't agree and decided to go to Nong Khai, to Thailand, to receive antivenom there. Yes, it's true.
This is the open questions from Dr. Rosie, the emergency department medical officer from Bentong. She would like to ask, in the case of a snake bite in pregnant woman, can antivenom affect fetus that can antivenom actually cross the placenta and affecting the fetus? So this is an open questions.
Yeah. Okay, I answer this question because I have the 5 cases in the pregnant. And my antivenom, Indonesia antivenom, biosafe from the color selasma, because the case is color selasma. No, the effect from the pregnant and the mother and the fetus. All the cases alive, mother and the fetus. And now I have the report from result from back from the home. This fetus is good condition, and 5 patient live.
I think Dr. Francis, your experience with was it JD? Was you had a case of pregnant lady?
I have not encountered a patient with pregnant yet.
I think Prof. Sataria would comment a bit about the quality and effect of antivenom for crossing the placenta or not. Prof. Sataria, are you there?
Yes. Okay, can you hear me well? Yeah. Okay. So the questions is about. I'm sorry because I did not listen to the questions carefully.
Can the antivenom cross the placenta to the baby if given? We know it's safe, but can the antivenom cross the placenta? I mean, for example, the QSMI antivenom.
I'm not sure about that. But anyway, if we have the pregnant patient, we give the antivenom to that patient. And from our data, I don't think that there were any adverse effects to the fetus in that patient. I think like that, but I'm not sure that the fetus will receive antivenom. But because of the the antivenom is the protein that might cross the placenta. It might cross. I'm not sure. I have to ask other for their opinions. Yeah. Thank you.
Okay, thank you very much. And anybody want to add on the question on that? Carl?
I think in the WHO guideline presented by Prof. David Worrell shows also that there is no contraindication for antivenom use in pregnancy.
Yeah.
So it should be same as anything else.
Yeah, another question from Nosham. Can a dog develop sort of immunity after 6 times from Naja Kautia? Yes, there was a male golden retriever was first bitten by Naja Kautia in 2013. The last one was in 2019. Yeah, Miat, you want to answer that? Or anybody can answer? Or probably Reza?
The question was on the dog.
Immunity.
Yes. Sorry, Dr. Zan, the reception is not very clear. I didn't hear that.
Okay. Oh, anybody else can answer that? The Vanessa? Yeah. Carl?
Well, we don't have a veterinarian in here, but from our contact with a lot of veterinarian, from QSMI, the snake farm, Dr. Lawan Chanhom, Dr. A few others, veterinarians, and even for myself, we have encountered snake bite in animals, especially dogs. Because they tend to instigate the snake when they find it, and they got bitten. And the effect that we see so far is similar to as per humans, but meaning that, let's say a cobra bite, the dog, you will get the local inflammation, the tissue necrosis, and obviously it goes into systemic, it goes typical neurological symptoms as well, stop breathing, and can die from that. Okay, so the question is, whether the antivenom works. Yes, it does. We have seen some of the cases responding well. Maybe not as much as we use in the dose in human, probably half than that. I don't know why, but some people say that the animals may have developed some natural immunity to venom over the millennia of evolution. But to say whether the dog will develop immunity, I would say the venom is as a foreign antigen, it will stimulate your immune system. You will produce some antibodies in yourself as per the horses that we use to develop antivenom, right? So you can actually have antibodies in yourself. The question is whether this level or titer of antivenom or antibody will remain high in the body over, for life or not. So like the horse, they will actually hyper-immunize the horse, inject many times to increase the titer of antibody in the body of the horse before they extract to make antivenom. So similarly, if you are actually, some people try to do this on their own body. We've seen cases, people, let the snake bite them many times, or inject the venom into them. We have cases in Philippines as well, and with mixed results. Some local tissue necrosis may occur, but that is because it's a different kind of toxins that causes a direct cytotoxic effect before the body can protect themselves. Maybe the systemic they can prevent, but not if it is highly cytotoxic venom. That's what we've observed from these cases. So yeah, I think it will be the same as per what we see in humans, I think, in terms of immunity to venom. Okay.
Can we go? Yeah.
Okay, so we go to the next question. So this is a very interesting question for us in a Southeast Asia region. So the countries such as Australia has been using the SVDK or snake venom detection kit and plus the clinical syndrome to help in the terms of identification of what type of snakes that bitten the patient. So any comment regarding its usage and for future development of snake identification, I think in our context in Southeast Asia. So open to probably Dr. Aika to have your point of view.
Hi, thank you, Dr. Ruth. In Malaysia, we don't have the kits, if I'm not mistaken. Studies have been done, but they were unable to identify specific. And so there were no kits produced. Like, for example, from the university that I came from, some researchers were trying to get this kit since there is a very high number of bites in Malaysia, but it was very difficult to identify specific species now. And of course, we know that to give antivenom, sometimes you need to know the specific species so that you can give the correct antivenom. However, with advanced research techniques now like proteomics, you know, we don't know. Maybe it can be done. Yeah, but that's my experience.
Yeah, how about Dr. JD in Philippines or Dr. Bond?
Yes, Doc. In the Philippines, actually, that's one of the projected projects of the Philippine Snakebite Initiative, is also to develop these kits that they use in Australia. I think our ITM has already had expertise on making detection kits, mostly for infectious diseases, but I think the same principle may apply for snake bites. Currently, our recommendation is still to clean the wound, but I understand in some countries they don't, for these kits to be used.
Any other additional input from our speakers, Dr. Vanessa or Dr. Miet?
So from my side, maybe from Laos, I can say I never felt the need to have these kind of tests. So in Laos, we have two kind of wipers. One is brown, one is green. And it's very simple during daytime to differentiate. And when the patient comes and said he's bitten by a brown snake and has a PT of more than 120 seconds, is for me clear. I give monovalent Malayan pit viper antivenom. For the crates is another thing, but the crate bite usually at night, and I would never rely on the description of the patient. So I give polyvalent neurotoxic antivenom unless the patient brings the snakes to the hospital and I can see that is a Malayan crate or that is a banded crate. So for me, the need to have a serum test for identification of snake in the Lao context is not necessary.
All right, Dr. Zainal, can we proceed with other questions?
Okay, there's another question. Has anyone faced a situation whereby they have required a ventilator for management of snake bite but have been unable to do so due to the demands of COVID-19? Probably Dr. Trimarani, can you share your experience in Indonesia?
Yeah. Okay, Dr. Jaina. I have many cases because COVID-19 in my country very highest to the patient and not enough to the ventilator. I have one cases from the Jakarta. One patient king cobra bite. I think my presentation they speak from the patient. I must do discussion with the doctor to give the priority of the patient, COVID-19 or to my king cobra bite. And this result of discussion, this COVID-19 is okay, not the first priority to the ventilator, and my patient king cobra bite the first priority of the patient. And you look in my presentation in my page, this patient king cobra bite live and have to the ventilator. I think it's difficult situation, Dr. Zainal, because COVID-19 is the fatality disease, and snake bite is fatality also. Yeah.
Okay, thank you. How about in Bonn in Philippines?
I'd like to comment on that. I always intubate patients in the ER, especially the critical ones. And I have found out that COVID usually use one mech vent at least 7 days. So when you intubate them, it takes so long. But if you have a snake bite, for example, for cobra, if you can give the antivenom shortly, then you can extubate the patient shortly. So if I'm the triage officer for the mech vent, I can just initiate mech vent on king cobra, do the bagging for and make sure that the antivenom is available to avoid bar trauma, and then shift the mech vent once the patient is extubated soon. We expect actually sooner extubation and weaning for fast giving of antivenin on cobra bitten patients who suffer from paralytic chest wall muscles. So that's my experience. And for COVID, once you hook the patients to mech vent, chances are you won't win them that fast. So if you can just give the mech vent to snake bite patient, you can save both lives. So that's what I practice in my institution.
Thank you. How about others? Anybody want to share their experience? How about in Malaysia? Reza, do you have any experience? You cannot hear. How about in Myanmar? Miat?
Dr. Zainal, and in Myanmar, most of the snake bite patients are viper bite, not cobra bite, and I'm not working at the hospital currently. That's why I cannot share my experience. Sorry for that.
Yeah, Dr. Job? How about in Laos?
Sorry, I missed this question.
About the needs of ventilators, does with the COVID patients who require ventilator will affect the patient who had been neurotoxic and then require ventilators, and because of the COVID,
Okay. No, I think in Laos, they have registered 23 cases of COVID-19 infections. No case was severe, so they didn't need ventilator. Okay. And so there is no competition with snake.
Okay. Aida, do you have any experience? Any comment in Malaysia?
No, unfortunately, I don't have any experience because our hospital is not a COVID gazetted hospital, so we do not receive COVID patients. But so far in the state of Pahang that we have been in, there were no problems, I think. The ventilators during the COVID period, the government, the Ministry of Health actually pulled a lot of teeth just to get a lot of ventilators for all of us. I think they did well. So I did not hear of any such cases.
Vanessa, Dr. Vanessa, how about your Vietnam? In Vietnam? Yeah. Dr. Vanessa, your experience?
Yeah, in Vietnam, I think because for the patient with a snake bite, they will admit to another department. So, and if, for example, if someone or patient have COVID-19, so they will transfer to another hospital. So I think it's not related together in my hospital. So I don't have any experience for that.
Okay, we go to the next question. Is the antivenom safe to be administered to the end-stage renal failure patients? Dr. Reza, your connection is still not good.
Yeah, can you guys hear me?
Okay.
Yeah.
Yeah.
Yeah. I have limited experience in treating ESR patient that got bitten. I don't know, maybe for some reason they don't get bites, but my personal view is actually shouldn't have any issue with treating this patient. We give same amount of antivenom.
Probably, if Dr. Vanessa would like to add regarding to that. And the antivenom actually safe to be administered for the end-stage renal failure patient.
Sorry, can you say it again, please?
And the one question of whether the antivenom is safe to be administered to the end-stage renal failure patients.
You mean the antivenom in Vietnam? So
for the renal failure patients.
For diabetic patient? Sorry, I don't want. I haven't the idea from the question.
Okay, I think it's okay because there might be some delay in actually internet lagging time.
It's raining in this region, so that's why it may be a bit lagging. So anyway, can we proceed? Is there any other pressing questions before we finish?
Yeah, another few questions. One is antivenom in Malaysia. Is it only available in government hospital? How about the availability in private hospital?
I think you can answer that, Zana.
Okay. In Malaysia, at the moment, only the antivenom is only available in government hospital. It's not because the private hospital doesn't was not allowed to buy, but probably they are not economically because the numbers of cases are very low in private hospital, and most of the time patients went to the government hospital. So that's why most of the antivenom is only available in government hospitals. You want to add on, Carl?
Next question.
Okay, next question. Do you want that I think there's 3 questions that is posted in the chat group, in the chat. But do you want to read on that? One is what lab investigation to be done in snake bite cases? Mia, you want to answer that? Lab investigation for snake bites? Not clear. JD, you want to answer that?
Well, it depends on the type of the snake. For example, the snake is at risk for DIC, then you have to go on the DIC panel. Well, acutely, there's not any test that is very useful. For hematotoxic, then we can use the test tube test we have. Hello.
Yeah, I think. Yeah, I just continue on that note that depending on what do you expect the patient may have, the problems that may have. So there are some general panels and there's some specific panels that you can send, and these are all depending on the snake species and knowing the species in your country, how they present their signs and symptoms, and how it affects systemically. So you only do blood tests if there is you suspect some systemic issues. You don't do from local envenoming. It doesn't get into the blood, so you don't doesn't affect so much. Therefore, if you want to more detail, you can always refer to the WHO guideline for 2016. There are a whole list of options that you can use for investigation, for blood investigation. For Malaysia, we have our guideline, and we have streamlined and reduced to the more clinically helpful tests. You don't have to do all tests to everyone. So there are tests that we do only once. There are tests that we do serially. So you can refer to the guidelines from each country. Yeah.
I think in the interest of time, because we already 6 p.m. So with that, I think we concluded the session and pass over back to the chairperson. Thank you.
Thank you so much, the moderators, Dr. Sabrina and Dr. Zainal. Thank you, everyone, for your question and answer. I now would like to invite our honorable panelists in the last minute, Professor David Worrell, to come on online. Hello, Prof. from Oxford. It's so nice to see you. So good, and really honored that you stayed on for the 3-hour sessions.
Not at all, Carl. It was a privilege to be allowed to take part in your session, and over the last 3 hours, I've learnt an enormous amount from all the speakers. I'd like to thank all the speakers. I've learnt a lot of new things, and it's a very exciting subject and extremely dynamic. And well done for organising this very timely meeting. So we all fear that COVID-19 is having an impact not only on our beloved snakebite patients, but on so many other non-COVID diseases. I just wanted to say very briefly that there is an opportunity for anyone who's been listening to this session or taking part in it to write an essay specifically on the topic of this meeting. That is the impact of COVID-19 on the management of snakebite patients, and to compete for a number of £500 sterling, that's about $700, something like that, US. I'm not sure how many ringgit that is, but it's quite a generous prize, an essay prize. So clearly this is appealing for younger investigators. So it would be an insult to ask our expert panelists, but I'm sure you have some younger people working in your departments, and this would be a really good thing while they're locked down in some cases to contribute. These prizes are being awarded by the Hamish Ogston Foundation, and I'm going to send to Carl the details, but you can find this on the website, and I'm afraid it's rather an embarrassingly bad website, but because it's got a lot of irrelevant snakes on it. Apologies for that, it wasn't my fault. And Dr. Ruth Sabrina has also very kindly offered to distribute this advertisement to the Malaysian Society of Toxinology. So that's all I wanted to say. For your younger staff members, here's a way to get a bit of money and spend a bit of time during lockdown. And thank you again very much indeed to all of you. It's been a marvelous experience. Thank you.
Thank you, Prof. Thank you, everyone. So I think with that, we conclude our session. We'd like to pass back to our technician, Encik Samsul. And before we go, please get your e-certificate. You can see that Dr. Sabrina already posted in the chat group. There's a link for your e-certificate. I think that will only available for a limited time. So I think some of our viewers are also on the live chat, live streaming on Facebook. So they are also, I think, given the opportunity to obtain their e-certificate via that Facebook online live. Okay. So with that, thank you very much for everyone. We will, this session is recorded, just to let you know, and hopefully we will be able to put it up on YouTube. And it is already, I think, available on the Facebook Live. But for the YouTube, we will take some time to edit a little bit, and we will post it via the MST, Malaysian Society on Toxinology website. So on behalf of all REX consultant, remote envenoming consultancy services, ASEAN, we say stay safe, and we'll see you again in our next series of talks. With that, take care and bye-bye.